and welcome to this session, guys. Today we are looking at the respiratory disorders, and we are focusing on the pediatric patients. Guys, as you know, a pediatric patient, of course, this will involve the infants, the toddlers, the preschoolers, the schoolers and the adolescent guys. Guys, you can use the link above to just guide you and help you understand the pediatrics. All right. So the respiratory system, this is one of the 12 body systems that enables us to breathe in and out. In that they are able to control both oxygenation and ventilation. So we do inhale. In oxygen and exhale of carbon dioxide. So the respiratory system is made up of several organs that normally are involved in the interchanges of the gases, which include the nose, uh, the nasal cavity, the pharynx, you have the larynx, the trachea, the bronchus, the right and left bronchus, the lungs, for that case, guys. So we have to know that the voice box is the larynx, the throat is also referred to as the pharynx, and the trachea is our windpipe, alright? So that we are not confused. In terms of classifying which one is the upper respiratory tract, which one is the lower respiratory tract, the upper respiratory tract is made up of the nose, the nasal cavity, and the sinuses, right? Remember the MEFs? Okay? Yes, maxillary, ethmoid, frontal, and the sphenoid bones, where we are likely to find this. So the lower respiratory tract, on the other hand, consists of the voice box, that's the larynx. Then you have the windpipe, the trachea, the lungs, the airways. This includes the bronchi and the bronchioles, and then the air sac, the alveoli. So the lungs normally take in oxygen, and the body cells need oxygen to live and carry out their normal function. Then they also do get rid of carbon dioxide, which is normally a waste product of these cells. So lungs are simply a pair of cone-shaped organs that are made up of spongy and pinkish gray tissue. They do take up most of the space in the chest, and they are covered by a membrane that we normally refer to as the pleura. They are separated from each other by the mediastinum, and this mediastinum also consists or contains a number of organs, including the heart and large vessels, the windpipe, the esophagus, thymus, and the lymph nodes. Guys, a link will be popping up. You can review the different types of body cavities, both anterior and posterior, and finally look at the contents of all those two categories. So the right lung usually has 3 lobes, and the left has 2 lobes. So when you breathe in, air will enter the body through the nose or the mouth, and then it will travel down the throat through the larynx and the trachea, and goes into the lungs through the tubes that we refer to as the main stem bronchi. So one stem bronchi will lead to the right and another one to the left. So in the lungs, the main bronchi normally divide into smaller bronchi. Then the bronchi will divide even smaller tubes that we refer to as the bronchioles. Then the bronchioles at the end, they normally end in tiny air sacs that we refer to as the alveoli. So in a nutshell, that's how the respiratory systems behave. So the actual exchange of gases will be will be done in the alveoli, right? And the alveoli have to be kept open, okay? And that's what P will be able to assist us, okay? Guys, if you want to look at the mechanisms that are involved in this, you could use the link on mechanical ventilation, where you try to appreciate the significance of P, the positive end expiratory pressure, that's the one that normally helps our alveoli to remain open at the end of expiration. So in our discussion here, we're going to concentrate to close to 15 disorders are associated with the respiratory system in pediatric clients. epiglottitis, cystic fibrosis, acute laryngitis, laryngotracheal bronchitis, asthma, infectious monoclonus, tonsillitis, and pharyngitis, bronchiolitis, bronchitis, tuberculosis, pneumonia, could be of course bacterial or viral. Then the foreign body aspiration, sudden infant death, and respiratory disorders are one of the conditions that we are going to focus on them on this particular presentation. So to start us up, well, guys, we have the epiglottitis, okay, and it's the organ that is affected here is the epiglottitis, okay, so it leads to the epiglottitis. So the epiglottis, of course, is just it's just a flap sheet of tissue here that is normally seated beneath the tongue at the back of the throat. Okay, the pharynx. So, and epiglottitis now simply refers to the inflammation and swelling of this epiglottis, and it's caused majorly by, or most often it is caused by an infection, but sometimes it could be as a result of a throat injury. It is more prevalent in children between ages 2 to 5 years old and the children without the HB vaccine. The mode of mechanism is usually respiratory or intimate contact, okay, with the patient. In terms of pathophysiology, you have the human influenza or the the Streptococcus pneumoniae will colonize the pharynx, and then there will be the penetration of this mucosal barrier, so it interferes with the membrane integrity. This provides an excellent opportunity for the invasion of the epiglottis, surrounding tissues, and this results in high fever, tachycardia. So with this edema, we now progress to the different folds. There are epiglottis, folds, the aortoids, nodes, the supraglottic, larynx, and resulting in these threefold events. So we could have redness with a large epiglottis. The patient also presents with tachypnea, increased respiratory rate, hypercapnia, respiratory acidosis, and decreased level of consciousness. Patient can also have dysphonia and stridor, dysphagia, and drooling for that case. We have to do a differential diagnosis here, guys. You will find that if the patient has a cough, that will be laryngotracheal bronchitis, and if the patient has no cough, that will be epiglottitis. Okay? So, epiglottitis is normally associated with the 4Ds that you'll hear people talking about. The first D is the dysphagia. Dysphagia is when a person faces swallowing issue, so has difficulty in swallowing. Dysphonia is when someone is having an abnormal or a hoarse voice. Then drooling, it will be the involuntary flow of saliva from a person's mouth. And then lastly, distress, where you are facing difficulties with breathing or getting enough oxygen for that matter. Okay. Remember, the most common cause here is what? Human Haemophilus influenza type B and the Streptococcus, species. So we could do some diagnostics, including looking for H. influenza, the human Haemophilus influenza type B. We do a chest film, and this one normally shows a thumb sign. A thumb sign is simply as a rounded thickening of the epiglottic shadow on a lateral next X-ray, giving the appearance of an adult size thumb. Okay, so and this is what we are looking at it. The white species will help with differential treatment. So the nursing intervention you need here to maintain a patterned airway and assess respiratory status, ruling out nasal flaring or tripod positioning and use of accessory muscles and retraction in the stride So in this, as a nurse, you're going to encourage the tripod sitting upright, the chin and tongue sticking out, so as they're able to help breathe with ease. And we are going to stop any oral inspection, because use of a thermometer swabs could lead to possible air obstruction, and ensure that you are doing the vaccination for this kind of class. You have to maintain nil oral and do not leave the child unattended. It's the responsibility of the RN to remain with the child and as they sort out their own issues. You know supine positioning and ensure adequate airway before initiating IV and fluids, and administer IV antibiotics, administer analgesics, antipyretics, administer corticosteroids. Then you do the nebulizer with the nephrine, which will help reduce edema and causes mucosal vasoconstriction for that. Remember, helix will be a mixture of helium and oxygen, and it normally helps reduce edema. The second condition, guys, now we can turn up to cystic fibrosis, and cystic fibrosis is an autosomal recessive disorder that normally affects exocrine glands. So autosomal recessive. So that means an individual must inherit the defective gene or copy of that gene from each parent to have this kind of disorder. Predisposing risk is that most Caucasians have this kind of the problem. So this problem is going to affect secretions in the eyes, secretion in the mouth, that's the saliva, secretion on the skin, the sweat, secretion in the stomach, the milk, the liver, the pancreas, and intestine. So all of them are going to show some signs and symptoms. If you want to diagnose these conditions, you normally carry out what we say or refer to as the quantitative sweat chloride test. So a mild electrical current will push the medicine into the skin to cause some sweating. Then the sweat is collected and the salt content is measured. So when it's measured, we are interested with the chloride in the salt, okay, or the sweat, okay. So you find kids with cystic fibrosis are likely to have 2 to 5 times the normal amount of chloride in their sweat, okay, for that case, right? Okay, remember, for you to get the best result, you must use at least 75 milligrams of sweat so as to get the satisfactory results of the test. For the pathophysiology of cystic fibrosis, well, we have already said we will have a cystic gene defect, which is autosomal recessive. That means you have to get the copy from the mother and the dad for this particular part. And then now after we have this, it will lead to impaired protein transmembrane conductance regulator, okay? The one that we abbreviate as the CFTR. So this in turn will affect the cyclic adenosine monophosphate, which normally regulates the chloride transport to epithelial cells on mucosal surfaces. So this will lead to decreased chloride secretions and leading to water and sodium reabsorption across epithelial cells. Remember, exocrine glands will start to produce now abnormally thick, tenacious, copious mucus, which result in about 6 symptoms. So that we are having interference in the transport system. So the chloride system is not being secretion will decreases. As a result, the clients or affected people are going to be producing abnormally thick, tenacious, copious amounts of these secretions. And this will result into a number of symptoms. Symptom number 1, you find that these viscous cervical secretions, they can block the vas deferens also, and it blocks the cervix. So someone will be asking, like, is that a family planning method? Maybe a blessing in disguise, guys, but this one is going to lead to infertility in some people, all right? Number two, these thick secretions are also going to lead to biliary fibrosis. Okay, because supply to that will be limited. So that will in turn cause cirrhosis and finally portal hypertension. Patient will also start presenting with ascites. Pancreatic fibrosis, which partly increases the risk of DM. Okay, remember DM. So insulin is not being produced. So insulin type 1 is likely to result from this kind of situation. So this is beside the pancreatic insufficiency. So the pancreatic insufficiency will lead to fat malabsorption that result in steatorrhea. So if someone you're checking about the stool, they will be having several fats in it, along with deficiency in vitamin A, and A means A, D, E, K. So when you have a deficiency of this group of vitamins, you are going to suffer from anemia, okay, because the clotting factors are not there, they are reduced. Bleeding again, the clotting factors are not there, even the bruising for that case, okay, vitamin K. All right. Number four is that when you have thick mucus secretions around, they are going to lead to stagnation of mucus in the airway. And when there's these secretions in the airway, it normally leads to bacterial affinity and colonization along this airway. Okay, so which can lead to an obstruction. And you know, this airway obstruction could cause chronic hypoxia since oxygen is not able to get to these other distal parts. This results in contraction and hypertrophy of pulmonary arteries and arterioles. Also, this will also result in copulmonale, and which could in turn lead to hypoalbuminemia, leading to an increased plasma. Equally, airway obstruction can partly cause atelectasis and emphysema, along with wheezing, cough, dyspnea, clubbing. So pulmonary hypertension could develop, which can also, just like the copulmonale, result in hypoalbuminemia due to an increased plasma. Number six effect of this secretion that are available is that we'll have production of abnormally thick, tenacious, copious mucus, which can lead to sweat that contains high amount of sodium and chloride ions. And you know, this will result in dehydration and electrolyte imbalances. Okay, the last one is that this secretion can also, lastly, when you have now this more mucus, that means that is abnormally thick, it can lead to decreased chloride and water secretion. So this further thickens secretions in the GIT, leading to interstipated meconium that can lead to intestinal obstruction, leading to features of abdominal distension, pain, nausea, and vomiting. Besides, decreased chloride and water secretion can also increase the risk of intersuspension. Okay? Alright. What are you supposed to do as a nurse? The nursing care, the nursing intervention. We can look at the system. The respiratory care, you're supposed to treat the pulmonary infection. Remember, the infections are coming as a result of increased bacterial colonization along the airway. Also, number two, you have to monitor respiratory status, and monitoring respiratory status, you look at the lung sounds, you look at the bronchial sounds, bronchovesicular sounds, and the vesicular sounds. You can also do the chest physiotherapy, forced expiratory technique. Of course, the forced expiratory technique here is the hoofing. So you want to teach these effective coughing techniques where you just hoof to expel the secretion, then you can actually add in a more effective cough. This method has been found to be so effective in removing secretions along the airway. Could also use the bronchodilators for the aerosol, so as they're able to dilate those ducts, and also physical exercise just to facilitate mucus expectoration. For the GI care, remember also cystic fibrosis normally interferes with the GI system. So what are you supposed to do? You have to monitor this system by monitoring the weight and the failure to thrive. Apparently, failure to thrive is one of the earliest feature for cystic fibrosis, fibrotic children. All right. Then we have to monitor for stool pattern, so that you are supposed to rule out the steatorrhea, that's excessive fats in the stool. Then you have the pancreatic enzyme replacement. Remember, the pancreas are not able to also release their secretions. So, and you can do this by administering it 30 minutes of eating, or administer with all meals and snacks. In terms of diet, you have to encourage a high calorie diet, a high protein diet, vitamin, a diet that is rich in vitamin A, in that case. Guys, a link will be popping up. You can review the different types of diet that are normally offered to different type of patients. Alright? So this is just the appropriate diet for a patient with cystic fibrosis. When at home, you're supposed to ensure that all immunization have been met and monitor blood glucose for signs of the DM, and provide adequate intake of salt and electrolytes, especially during the warm weather. Right. So next condition here is acute laryngitis. Laryngitis, guys, inflammation of the larynx, and it's more common in older children and adolescents. And the common cause is the viruses. So that means it's what? It is self-limiting. Okay, a self-limiting condition. Okay, so if this condition lasts for more than 3 weeks, then it should be termed as chronic laryngitis. Remember, patients with laryngitis will present with hoarseness, the sore throat, congestion, fever, headache, myalgia, and malaise. Okay. Remember, the most common viral here is either the influenza or the adenovirus. Okay, bacteria could also include the Moraxilla catarrhalis, the Streptococcus pneumoniae, and Haemophilus influenza, especially from in the winter and early spring. Okay, so people suffering from sinusitis, nasal obstruction, overuse of the voice, alcoholics, and smokers are more prone to this condition. So if you want to treat it, you have to give, because this is mostly viral, you have to give supportive care, especially the fluids and humidified air, and then assist the patient to expectorate the secretions and avoid the spread of infection as you maintain the patent airway. The next condition, guys, is laryngobronchitis, and tracheal bronchitis is affecting the larynx, the tracheal, and the bronchi. Right? It's more common type of group disease. Okay, and affects children who are younger than five years. Right, younger than 5 years. The causative factor could be the para-influenza virus, the respiratory syncytial virus, influenza A and B, rhinovirus, coronavirus, and mycoplasma pneumonia. So patients with laryngotracheobronchitis are going to present with a barky cough, and this is majorly due to the narrowing of the subglottic region of the airway. Also, they are going to present with inspiratory stridor, and this is because of the narrowing of the airway. Also, hoarseness because of decreased mobility of the vocal cords, and then gradual onset of low fever, and then hypoxemia along with respiratory acidosis, and even respiratory failure for some time. So in terms of treatment, we do the medication management, and you maintain a patent airway along with high humidity with cool mist to relief, okay, for that case. So remember to assess respiratory status, do non-invasive cardiac and respiratory ABG monitoring, and keep the child comfortable while allowing the caregiver to lie next to the child in the mist tent to lessen anxiety. You have to modify the treatment to the mist, to the cool, moist mist, blowing directly towards the patient from the nose when the child is not able to tolerate the mist tent. Alright? Okay, guys. The next condition is asthma. Alright, so asthma is a chronic inflammatory disease of the airway. So that causes airway hyperresponsiveness, we have mucus edema, and we have the mucus production. Predisposing factor, it could be genetic, those guys who suffer from atopic, and being female normally actually increases the risk, of course, for this one. Okay, along with the exposure to allergen, respiratory infections, air pollution, being either an active or a passive smoker, or failing to do some exercise, hyperventilation, weather changes, exposure to sulfur dioxide, exposure to some kind of foods and medication can predispose someone to having asthma. So the muscles will tighten up and the airway will swell. So mucus in the airway will clog the airways, and lungs will have a difficulty moving air in and out for that case. So the guys will present with expiratory wheezing, okay, and will have chronic cough or shortness of breath, the dyspnea, non-productive cough, tachypnea, chest pain, irritability, restlessness, use of accessory muscles, silent chest. And the silent chest simply means they have absent wheezing and coughing due to the fatigue and inability to move any air through the severely constricted bronchioles. So this one normally precedes the respiratory failure and is normally a life-threatening medical emergency. So you're supposed to assess respirations and the lung sounds for this patient, and you monitor the peak expiratory flow as the bronchospasms forces the gland to work hard in exhalation, and then expiratory phase becomes prolonged. All right, it becomes prolonged. So we have the environmental manipulation, where you prevent and reduce exposure to airborne allergens and irritants, and you avoid extreme weather that could trigger asthmatic attack. And then you could have diet. In terms of diet, you're looking at avoiding foods known to provoke the symptoms for this case. And then you avoid aspirin for aspirin-induced asthma for that case. So initially, you will normally give these children the bronchodilator. So we have albuterol, between 2.5 to 5 milligrams of nebulized albuterol you can be able to be given to a patient, and you can redose it after 20 minutes. So we have the management of the asthma in terms of giving the drugs, and we normally abbreviate it using the word asthma. So that A stands for the adrenergic beta-2 agonist, and a good example is albuterol, and they work by relaxing the smooth muscles in the airway, and this provides rapid relief of bronchoconstriction. Next, we have the steroids that are abbreviated as S. So we have the S for steroids. So we could have the inhaled corticosteroids, and of course they work because they have an anti-inflammatory properties, and these anti-inflammatory properties will reduce airway inflammation and relieve some of these symptoms. T stands for theophylline, okay. Theophylline, this is aminophylline, theophylline. This is act by bronchodilation by relaxing the smooth muscle of the airway, and they may also have some anti-inflammatory effects. H is for hydration, IV. So here we give intravenous fluids. This is simply supportive during severe attacks to maintain the overall hydration and support respiratory function. We could also give oxygen using the mask oxygen. Okay, so this supplemental oxygen is delivered by a mask to ensure adequate oxygen intake during times of increased respiratory rate. Then A, we have the anticholinergic, where an example is the ipratropium bromide. And this one causes relaxation of smooth muscles by blocking the action of acetylcholine. This is the neurotransmitter that can cause bronchoconstriction. And then lastly, we have the leukotriene modifiers. So an example is the Montelukast, and this is a modulation. So modulation, it modulates the inflammatory pathways by blocking the effects of leukotrienes. Leukotrienes is a substance contributing to inflammation. Guys, a link will be popping up on the different inflammatory mediators, of which leukotriene is one of them, and the drug that we use to block this is the Montelukast. All right. Guys, at this juncture, I want us to look at the infectious monoclonus, and it's also referred to as the kissing disease. So it's transmitted through saliva, mucus, or tears. And this acute it is an acute and self-limiting infection among young children, especially between ages 15 to 25 years old. And the major causative factor is EBV virus. Epstein-Barr virus. So patients are going to present with malaise, sore throat, fever, lymphadenopathy, pain in the left upper quadrant if there is splenomegaly, body aches, loss of appetite, and fatigue. So when we want to diagnose, because we know the most causative factor for this, we simply look for that causative factor. So we have the Epstein-Barr. And we know the incubation period is between 4 to 6 weeks. It can also be established by atypical leukocytes and a positive heterophil agglutination test for that case. So in terms of treatment, you simply give mild analgesics and diffuse fluids and humidified air. So if the patient has splenomegaly, you have to avoid contact sports, so avoid rupture. And then on the diet, you have to give that meets the growth and the needs as particular the age group, and then advise the family that regular activities may resume when the acute phase of the illness has ended. Okay, this is 4 to 6 weeks. So you can take an over-the-counter pain relieving medication. You can drink plenty of water or tea. You can eat cold foods like the post and gargle with the salt water. And then use an ice pack to help lower body temperature at some point. Alright? Okay, guys. The next condition is tonsillitis and pharyngitis. Guys, a link will be popping up for this condition, which we have already reviewed for that case, including the precaution measures that you are supposed to uphold when you are dealing with patients with tonsillitis and pharyngitis. All in all, we are saying that this condition is common as a viral infection, and it is caused by group A hemolytic streptococcus, abbreviated as GABHS. Group A beta hemolytic streptococcus. Alright? The patient will present with sore throat, palatine tonsils will enlarge with edema, and the tonsils will be meeting in the midline in the throat, and you have difficult breathing and swallowing. All right. Also, the patient has fever, persistent cough. So with this group A beta hemolytic streptococcus patient, you are going to have headache, abdominal pain, nausea, vomiting, and diarrhea. So since we know the major cause of this condition is the group A beta hemolyticus, in diagnosis we do a throat culture for this bacteria. All right. So in terms of treatment, it depends. Is it viral or bacterial? So if it's viral, we know it is symptomatic, so you treat as the symptoms do appear. And then you have warm saline gargles. You gargle with him saline. And if left untreated, you find that this group A beta hemolyticus could lead to scarlet fever, otitis media, suppurative infections surrounding the tissue. We could also do tonsillectomy with recurrent strep infections and massive hypertrophy. But you have to know that this tonsillectomy is normally reserved for children who are older than 3 years old, and this is because of due to excessive blood loss that is normally associated with this procedure of removal of the tonsils. And also there is a potential for the tonsil to grow back, so we have to ensure that we have made the 3 years old for that case. We can also use an ice collar to decrease pain and for vasoconstriction, and also acetaminophen for pain removal. Alright. Nursing intervention will be so key post-tonsillectomy. So, like post-tonsillectomy, the slicing normally occurs approximately 7 days post-tonsillectomy, and this normally increases the risk of bleeding. So, you have to teach the caregivers to observe for the signs of bleeding, which could include frequent swallowing or throat clearing. Yeah, so the child may also experience increased pain, so you have to teach the parents that the child should refrain from strenuous activity or contact sports for at least 7 to 14 days post surgery. Number, do not fraction. All right, you minimize crying, and nutrition needs nil to cool, nil per hour to cool, clear as you migrate until you get to that level. Okay guys, that was all about the pharyngitis and tonsillitis. So for now we are going to look at bronchiolitis. Bronchiolitis. So the bronchiolitis. Alright, okay. Fine, so we can be able to appreciate the normal bronchial tubes here, and then the bronchial tube with bronchiolitis, where we have necrosis and loss of epithelium, mucus buildup, inflamed tissues, okay, with smooth muscles tightening around the tubes, right? So the major cause is the respiratory virus, the RSV, and because of that, because it's a virus, it's usually self-limiting. So it begins with the viral symptoms, respiratory symptoms such as rhinorrhea or congestion, and then it progresses to lower respiratory tract symptoms, including the cough, the wheeze, and the tachypnea. So you have to advise the mother to continue breastfeeding and provide additional fluid to the baby, and also use saline drops and suction the nice using a suction bag to remove secretions before feeding or before bedtime. Alright? Next is bronchitis. So this is the bronchus, inflammation of the trachea and the bronchus. Okay, the bronchus. Alright, so the bronchitis is here. Okay, the bronchus. This is bronchiolitis. Alright, inflammation and swelling of the bronchioles. Right? Hope you can be able to see the difference between the two. So bronchitis can also be referred to as the tracheobronchitis. So the trachea and the bronchitis are the one inflaming, and it's mainly viral. So patients will present with fever, dry hacking, and non-productive cough. That is normally worse at night and becomes productive in 2 to 3 days. So you remember, you have to treat the symptoms as necessary. It's viral. You have to maintain or monitor for respiratory distress and provide cool humidified air to the child. You encourage increased fluid intake, administer antipyretic and cough suppressants just to promote rest in this child. The next condition, guys, is pneumonia. So inflammation of the pulmonary parenchyma or the alveoli or both. Okay, and major causes in pigs could be by virus or the mycoplasma bacteria or aspiration of foreign substances. But we have more cases of virus compared to the bacterial. So, and it's very common in crowded living conditions and in children of ages between 5 to 12 years old. When you look at bacterial pneumonia, this is more serious and it requires hospitalization when the pleural effusion or erythema accompanies the disease. So in terms of assessment, you find that an infant in acute onset, you find that the infant will be irritable, will be lethargic, will demonstrate poor feeding, and there will be abrupt fever, which sometimes may be accompanied by seizures. Or could also have infants could also show suffer from respiratory distress, where there is air hunger, they have tachypnea, and they have the psychomoral cyanosis. For the older children, they could show or manifest with headache, chills, abdominal pain, chest pain, meningeal symptoms, hacking, non-productive cough, diminished breathing, consolidation. Breathing sounds will be more pronounced. Okay, so they'll be decreased breath sounds, and infection sometimes solves, and then the cough becomes productive. All right, that is what you need to expect. So in terms of intervention for a ped with pneumonia, you're supposed to put them on antibiotic therapy, the safe antibiotics. A link for the antibiotic therapy will be popping up. You can review the different types of antibiotics. You could also put them on oxygen if they are having distress, respiratory distress, and put the child in a cool mixed tent. So cool humidification normally moistens the airways and assists in temperature reduction. Also, this we suction the mucus using the bulb syringe and do continue monitor and every 4 hours. We promote bed rest and encourage child to lie on the affected side. Okay, that's the unilateral. If this case is unilateral, because sometimes it could be both lungs. Okay, but if it is one-sided, we help them to lie on this affected side, and this normally helps just to splint the chest and reduce the discomfort caused by the pleural wrapping. Right, so administer antipyretics to at least work on the temperature. All right, okay guys, so you also need to monitor the temperature so that you rule out the seizures, all right, and institute the insulation precaution measures. Precaution measures will be popping up, and you can also still review the lecture on the isolation precaution measures. Next, administer cough suppressant, and fluid accumulation in the pleural cavity can require the thoracentesis, where we can use to obtain the culture from it and know which kind of microbes are found there. And we can also use the same thoracentesis to instill some antibiotics directly into the pleural cavity. As for the aspiration pneumonia, here you'll find that we have food or secretion and liquids and other materials that can cause this lung and chemical pneumonitis. So the patient presents with increasing fever, cough, fever, and foul smell, sputum. So if we want to prevent this, we normally give the heptavalent pneumococcal conjugate vaccine, okay, the PCV, right? PCV10 for us here. For the viral pneumonia, we could have mild fever, slight cough, malaise, high fever, severe cough, and diaphoresis. So could have non-productive or productive cough of small amounts of whitish sputum. So could have wheezes and fine crackles. So the intervention in this case could the patient could have symptomatic, like we could do symptomatic treatment for the viral one, okay, because there's no definitive way. So we do the symptomatic as we treat as the symptoms come, administer oxygen with cool humidified air, and also administer and also take care of the temperature by administering the antipyretics. Okay, so children, you have to know that children with respiratory disorder should be monitored for weight loss and for signs of dehydration, which could include a sunken fontanelle, non-elastic skin, targar, decreased and concentrated urinary output, dry mucous membranes, and decreased air production. Okay guys, that was all about the pneumonia, guys. Now we can focus our minds to the tuberculosis. All right, tuberculosis, guys. This is a contagious disease that is normally caused by Mycobacterium tuberculosis, right? So in Kenya here, to prevent some of this, we normally give the BCG vaccine, right? And the route of infection for tuberculosis is normally through inhalation of droplets from an individual with active tuberculosis. And it's very common associated with the low-income earners and some type of ethnic groups that normally encourage that closeness for that case. So patients are going to present with malaise, fever, cough, weight loss, anorexia, lymphadenopathy. And some specific symptoms could relate to the lungs or the organs that are affected, maybe the lungs, the brain, or the bone. We could also have asymmetrical lung expansion, a decreased breath sounds, crackles, and dullness when you are percussive. So we normally do the PPD test, guys, just to find out whether you have been exposed to this disease, and it normally takes around 2 to 10 weeks after initial infection, right? So we want just to determine whether you have been infected and if you have developed sensitivity to this protein, tuberculous bacillus. So remember, this process does not confirm if you have TB, all right? We just want to see if you have been exposed. So after a child reacts positively, the child will always react positive to this, all right? It means you have been exposed to this, okay? So there is even no need for vaccination for that case, okay? So for those who have maybe more than 1 year and you are encountering these children for the first time and you are wondering whether to administer the BCG vaccines or not, you are supposed to do this PPD test first to find out, all right? So the result will depend on how you have been done. So like it could be greater than 15 millimeters if children are more than 4 years and who do not have any risk factors. That is what you pick as positive, okay? Or less greater than 10, right? Or greater than 10. So these are children who are 4 years, in children with chronic illness or at high risk of exposure. So this will be treated as positive. Or 5 for the highest risk factors, this immunosuppressed. If you have 5, then that will be considered as positive. So, in TB patients, you're supposed to try and get the definite diagnosis by doing the sputum culture. Could also do chest X-ray as supplemental, and sometimes we do the gastric washing, where you aspirate the lavage contents from the fasting stomach, and it can be obtained. And this is normally done early morning before breakfast. Medication, you could give a 9-course of isoniazid just to prevent latent infection from progressing to clinically active tuberculosis. And to prevent initial infection in children, in high-risk children, we could have a 12-year-old course maybe prescribed for a child who has been infected with HIV. So clinically active TB, we normally give a combination of drugs where we have isoniazid, rifampicin, and pyrazinamide, okay, daily for 2 months, and then isoniazid and rifampicin twice weekly for 4 months. You have to teach this the parents some of the common side effects, like when you're using the rifampicin, it's likely to change the color of the secretions in your body, like the tears, right? So they could change the color, and that should be treated as normal. We could use the DOT, that is the directly observed treatment for some children, especially those who are not complying with the treatment. We could also place these children with active TB and on respiratory isolation until these medications have been initiated and sputum culture are showing diminished number of organisms, right? Or the cough is improving. Remember, for TB, you have to put this patient on isolation precaution, especially the respiratory precautions, where you're going to use an N95 or an N100 mask. Or beside, you have to provide adequate rest and adequate diet to the patient and instruct the patients about measures to prevent TB. Alright? Next, we have the RDS, guys, respiratory distress syndrome. Okay, predisposing factor is anybody who is born below 36 weeks of gestation. So the risk is higher when it's below than 28 weeks. Okay, so this respiratory condition is caused by deficiency of lung surfactant, and it mostly affects the preterm. So we normally have the alveolar collapse for that case because of lack of surfactant. So patients who present with respiration breathing of greater than 60 breaths per minute, and the cyanoised with retraction, chest retraction, nasal flaring, and flaccidity. Diagnosis: we normally do an X-ray, which normally reveals the fibrosis of the lungs. Right. So treatment: we could do prenatal steroids. So if these mothers who are at risk of giving birth to preterms, we can give them betamethasone. All right. And for the kids, we could give them administration of exogenous surfactant for kids. Okay. Or we can give of course, the diuretics, the bronchodilators, and oxygen therapy. Or remember, you observe the infant's response to respiratory therapy, monitor the pulse oximetry and arterial oxygenation to just see the respiration status, and sanction and hyperventilation when indicated. As for the SIDS, this is the sudden infant death. Okay, it is also referred to as the crib death, right? And it's the unexpected death of just healthy infants, and it's usually younger than 1 year. The infants, guys. So there is normally no adequate cause of death, and it's common during the winter. So we have 3 months of age. And mostly boys affected, right? It occurs at sleep, and we have some races that are very susceptible to this: Native Americans, African Americans, and Hispanics, and people of lower socioeconomic groups. Possibly, these are people who do share the bed with these infants, right? So could also have decrease when breastfed infants are sleeping with a pacifier, right? There's a higher risk when your child is in prone position. They use soft bedding and sleeping in a non-infant bed, or overheating the thermal stress, or you're co-sleeping with the infant, or the mother has been smoking cigarette or abused drugs during pregnancy, and exposure to tobacco smoke after birth. All this increases the risk for SIDS, sudden infant death. So we assess, you find the child could be, they may not be breathing, they are cynosed, lifeless. Some of them could have frothy blood-tinged fluid in the nose and mouth, and some stool-filled diapers. Okay, so the infant handled under disabled beddings. How to prevent it is the best position for sleeping. It has to be supine for these infants, okay? And you get the mothers about the risk factors, and you monitor for positional plagiocephaly. This is normally caused by supine sleeping position, there where we have now the flattened posterior occiput. So assist in preventing positional plagiocephaly, and teach parents to later to or better head positions during sleep. So if SIDS occurs, you have to provide support as the parents will be grieving. All right. Okay. Next, we have the foreign body aspiration, and this majorly affects the toddlers, guys. So here we have swallowing and aspiration of foreign body into the airways. Remember, at this stage, they are very inquisitive. They are doing so many experiments, and they are likely to put anything that appears like food in the mouth, and this is so risky. So somebody will be choking, they'll be gagging, they'll be coughing, there will be retractions, bisinus, dyspnea, stridor, cough, hoarseness. We're going to have bronchial obstruction, paroxysmal cough, wheezing, asymmetrical breath sounds, or dyspnea, obstruction, progression, unconsciousness, and asphyxia, guys. So the intervention, you really have to assess, guys. You have to, this warrants emergency care, right? Emergency care, where you have to see if there's an effective cough or not, or so if there's an effective cough, you have to encourage them to cough, and you continue to check for deterioration to ineffective cough until obstruction is relieved. That is okay. If there is ineffective cough, you have to determine whether it's unconscious or conscious. If they are unconscious, you have to open the airway, you give 5 breaths, and you start CPR. Equally, if they are conscious, you have to give the 5 back blows, okay, the slap tap, and the 5 thrusts, okay, the squeezing in. So remember, it is chest for an infant and abdominal for a child who is greater than 1 year. Right, guys, a link on how to help someone who is choking will be popping up. You can follow up and see how to assist someone who is choking, both an adult and also an infant. Okay guys, so that's the end of our presentation, guys. We really appreciate you for the different conditions that you have been following through this presentation, starting from the epiglottitis up to this case where we have looked at the foreign body. Right, so we can finalize by looking at the tracheostomy care for pediatric clients. So if your patient is on tracheostomy, guys, you have to ensure that the clients or keep on encourage them to always carry 2 tracheostomy tube. One should be the same size as the one that they are using, and the other one should be the smaller one, so that in the event that the larger tracheostomy tube meets an resistance, the smaller size tracheostomy tube can be used, must be used. Besides, we also have humidification, because humidification is very crucial for patients with tracheostomy, because we have bypassed the natural humidification process in the nose, right? So humidification normally keeps the secretions thin and reduces mucus plugs, and humidifiers must be retained even with increased secretions, and furthermore provide safe sanctioning specified in the market. All right. Okay, guys, thank you so much for your time. We have been looking at all the respiratory disorders, the most commonly tested respiratory disorders in pediatrics. Guys, you can follow the link and get into the description section. You're going to get quizzes, free quiz for all the conditions, starting from epiglottitis up to foreign body. Thank you so much, guys. Thank you so much, and let's meet in the next session. Bye bye.